Hey there, I am so excited to cover this article today. Today we're talking about dystonia and neuroplasticity and this very interesting correspondence that Mark Hallet shared in the most recent journal of Parkinsonism and related disorders. It's called Dystonia, the ability to forget. So we're going to dive in. We're going to chat about this. I want to say hello to Ellen. I saw your name pop up. Great to see you here. And if we haven't met, my name is Julie Hirschberg. I am a neurologic physical therapist, a person very passionate about dystonia, and I am the owner and founder of Reactive Therapy and Wellness. We're in the Los Angeles area, and we provide integrated neurologic rehabilitation to people with neurologic disorders, including dystonia and FND, concussion, post-stroke, and many, many other things. So I love to come and share about some of the latest research or articles or things that we're learning about a lot of these different disorders. And today we're going to do an article review, and it's not a research article. It's really a perspective piece, and it's by one of my idols in movement disorders, who is Mark Hallet. So I'm going to share here. This is the article. It's in the journal Parkinsonism and Related Disorders, just recently from 2025, and it's called Dystonia, the Ability to Forget. And even by the title, I was like, what is this even about? Like, I need to learn more. I need to know more. And anything by Mark Hallet is usually quite thought-provoking, not just for me, but for all of us. So I want to share what he shared in this article. And I'm going to share with you, I don't agree with all of it. I definitely agree with major points in here, but I don't agree with all of it. And I'm going to tell you why. And I'm going to share some other studies and resources. And by the way, if you are not on our newsletter, I send out a newsletter every Friday to clinicians, every Monday to patients. I will send out this video. I'll send links to all the articles. Get on our newsletter. What you can do is go to the post that announced this video on our profile and comment newsletter, or after this video is the recording is posted, you can comment newsletter and I'll send a link to that. So let's dive into this article, and it is so very interesting. So let me start off by, I'll stop sharing the name of that. Let's talk about dystonia and what it is and the distinctions he makes in this article, because it's really important. And this is actually kind of where maybe Mark Hallet and I might diverge in our opinions about dystonia. So dystonia can happen for many reasons. You can see it as part of Parkinson's. It can be a part of a genetic disorder. You can have it post-stroke. You could have it just idiopathically, meaning we don't fully know how it started. But often those idiopathic cases are in people that do repetitive motions. Musicians, writers are two big components. It can occur with walking or running. We see a lot of people with runner's dystonia. So what dystonia might look like can be quite variable. You can also have functional dystonia. And I've shared this before, and I'm just going to pull it up here. We have this as a whole post, and I've done a whole live on some of the articles that differentiate idiopathic dystonia from functional dystonia. But this is one of the pieces. And here's a really important point for all my clinician friends and for people who might have dystonia. Oftentimes you can have both. So a functional dystonia can co-occur, can develop alongside dystonia. Some of the big differences between those, typically idiopathic dystonia is evolving over months to years, whereas a functional dystonia evolves very quickly, though it's not always the case. Often a functional dystonia does occur after a trauma or physical injury. In a idiopathic dystonia, it's not always identifiable because it could happen over time with repetitive activity, like with running, like with playing a musical instrument. Typically, the functional dystonia has a very rapid progression. Like all of a sudden, a person has a very fixed dystonia. And I'm doing this because this is a common position: elbow flexion, finger flexion, wrist turned in. It can happen very rapidly, whereas an idiopathic dystonia can have a very slow progression, and it doesn't typically have any remissions. Often a functional dystonia can have remissions, and here is the big kicker. And I'm going to talk about this because I think it's really important from a brain standpoint. Functional dystonia will tend to have a variable pattern of muscle contractions. Now, not necessarily a fixed dystonia. So a fixed dystonia might stay fixed into a position. But other forms of dystonia, and dystonia on a whole is an involuntary movement disorder where you get some sort of torsional activity of muscles. So you can have it in cervical dystonia with a head turn and a tilt. You can have it in the foot. Often it's the foot turning inward and down. You can have it in the hands, but it's completely involuntary. In functional dystonia, we can see those muscle patterns change. We can see that it occurs with different finger muscles. We can see that it occurs different neck muscles. It might change day to day or hour to hour. It might change with attention to the muscle contractions. Whereas an idiopathic dystonia has a repeatable pattern of muscle contraction. And this repeatable pattern might be seen on EMG, so you could actually test for it. This is why they might treat it with Botox, which has some efficacy in dystonia, more so in cervical dystonia than other dystonias. Whereas Botox wouldn't be indicated in something that is variable, because you wouldn't want to Botox one muscle one day and then need a different muscle the other day. But this variability in functional dystonia is a key distinguishing factor. And I think this is the part that Mark Hallet didn't comment on in this particular perspective piece that he wrote. So I want to stop sharing this. I just wanted to give a little bit of background, like what is dystonia? What are the differences here? Because even though there are differences, how we might assess things, how they might be treated might have some overlap. But what Mark Hallet talks about, dystonia, the ability to forget, is actually really, really key in idiopathic dystonia. And so let's talk about what he talks about in this article. So he actually starts off the article, and I really appreciate this. He says, functional dystonia and other types of dystonia may have some differences in presentation. The general appearance might be similar, and neither have a pinpoint pathology in the brain. They are both network dysfunction disorders of the brain, dystonia and functional dystonia. And he describes network disorders as the information travels incorrectly in brain pathways. I also just really love that. It's very simple, very understandable. A network disorder is when information travels incorrectly in brain pathways. Now, here's where I think he gets it wrong. And if you have functional dystonia, you're probably going like, oh my gosh, Mark Hallet, how can you say this? But he says there's one significant difference: the ability of functional dystonia to get better, and sometimes very quickly. Hello, have you worked with people with functional dystonia? Yes, it can get better. Sometimes it could happen quickly, but sometimes not. Sometimes it takes a while. Mark Hallet is a researcher and physician. I'm a physical therapist. I work with people with dystonia, so I can see this. Also, I would say the thing that is missing from that sentence is that people with idiopathic dystonia also can get better. Now, do I think it takes a very specific approach for both of those to get better? Yes, I do. Has it been shown in large randomized controlled trials that people can get better with things like physical therapy, occupational therapy, speech therapy, psychology? No, it hasn't, because dystonia and functional dystonia are both really rare and have not been studied extensively. Now, I'm going to share some of the research that has been shown to help both. But frankly, I think he gets it wrong. Number one, people with functional dystonia don't always just get better quickly, like magically. And number two, people with idiopathic dystonia can also get better. But I do agree with you, Mark Hallet. I totally agree. Idiopathic dystonia doesn't get better quickly. I've never seen it. It takes time. And I think that is the point of this article, because the dystonic pattern has been really overlearned, and the person with dystonia is lacking, I'm going to say, quote, the ability to forget, because we're not really talking about brain memory forgetting. We're talking about motor learning pattern forgetting. And I think that's the brilliance of this lovely article. But I just have to tell you where I disagree. I actually think it would be really insulting to most people with functional dystonia. So he goes on to talk about, in the adult onset dystonias, there has been found in the literature abnormal plasticity occurring, meaning these, just like he said, this network pathology, the way different areas of the brain are communicating and information is passing is not normal. And it is the cause of the dysfunction. Now, here again, this is a very short article, by the way. I highly, highly recommend it. But again, I'm telling you where I disagree. He says training for normal movements generally does not help. I beg to differ with you here, Mark Hallet. Now, I think what he's thinking is, like, let's say you have a writer's dystonia, and so typically in a writer's dystonia, instead of having discrete finger movements, you have really involuntary, inappropriate hand muscle contractions of muscles that you don't even need to help with writing are contracting to help you write. And just practicing hand exercises is not going to help. I think that is what he's saying here. Practicing the opposite movement, it's not going to help. That's never been shown to be helpful. And frankly, I've never seen it be helpful. Now, if you add sensory training to that, maybe so, but he doesn't talk about sensory training here. I would love to have a little talk with Mark Hallet about sensory training. I think that's missing from this article. So he says training normal movements generally does not help an idiopathic dystonia. Medications, not super helpful. Deep brain stimulation can help, but as soon as it stops, the symptoms are back. So you need deep brain stimulation all of the time, and it can take a really long time to get benefit. And it basically, what he's saying is really hard to undo the neuroplastic changes that happen in idiopathic dystonia. And I agree. Anybody that you know that you have met with runner's dystonia, with writer's dystonia, with musician's dystonia will absolutely tell you that it is hard. They have worked extremely hard to undo some of this aberrant, abnormal neuroplastic changes. Now, this is again where I think he gets it a little bit wrong, and I'm going to share some evidence for it. But I want to start because he talks about idiopathic dystonia being different from functional dystonia in this plasticity problem that is occurring. However, in a moment, I'm going to share some research with you in functional dystonia that does show there are neuroplastic changes. I would argue that both functional dystonia and idiopathic dystonia both have neuroplastic changes, but they are different. So in the article, he talks about some of those neuroplastic changes that have been studied and have been shown in idiopathic dystonia. And he's using a very specific measure of neuroplasticity, not something that I do, not something that a lot of people do, but these are things that they might do in a neuroscience-based research to look at the brain networks and the changes. So things like paired associative stimulation, long-term potentiation, long-term depression, these are measures of neuroplastic change that have been studied in idiopathic dystonia, both small studies in adults and some other studies in animal models. I want to say they're rat models, but I can't confirm that, but they're in animal models. So I think this is important that he's looking at neuroplastic changes studied in this very specific way. So looking at long-term potentiation, long-term depression, looking at transcranial magnetic stimulation as measures of neuroplastic change. And what he talks about with these changes is the abnormality in dystonia. It can either, and this is, I'm going to quote it, can be either learning that can get stuck. I actually really like how he frames that. Or the inability to forget, independent of some sort of learning abnormality. We're not talking about learning like school learning, book learning, anything like that. We're not talking about memory of facts or people's names. We're talking about motor learning. And so I love that he breaks down these potential two types. And then he goes in, and don't worry, I'm going to come back to the functional dystonia piece. But then he goes deeper to talk about memories. So, and again, we're thinking of memories in terms of motor learning and the body. At least it's how I'm interpreting what he's saying here. So memories have three components: induction, maintenance, and expression. And he talks about the difficulty with forgetting. So you've learned a motor pattern. I think this is so clear for the person with runner's dystonia. Somehow your body learned and developed a motor pattern that is really unhelpful for you. Oftentimes in runner's dystonia, it's a foot inversion and plantar flexion. Sometimes it's at the hip or knee, but you've learned this. What he says is then it maintains there. And the difficulty with forgetting, your brain it holds on to it. It doesn't forget it. It holds on, and it's in the maintenance phases. What he talks about, and I think this is so fascinating when it comes to the brain, generally, what he says, after something is learned, there are changes in those brain connections and synapses that are irreversible. Now, of course, you can always learn something new. So if, like he even says, if something appears to be forgotten, like after you've learned it once, it's not really forgotten, because when you do it again, it's actually faster. And this is kind of a network. It's task specific. This is how the brain learns things. They're related to tasks. This is why in idiopathic dystonia, you might develop dystonia, and it is in running, right? And it's typically even running at a very particular pace. So you have a learned pattern of movement at a particular pace. And then you find, oh, well, if I run backwards, I'm okay. Or if I run really slow, I'm okay. Or if I run sideways, I'm okay, because that's a different task. But what he talks about is the reason this persists is we can't unlearn it. we struggle to forget it. And that might be the problem in dystonia. This really rings true for me when just because I've worked with a lot of people with dystonia, and I can see how hard it is to unlearn that pattern, how hard it is to change that pattern. And so I love this idea that potentially really where we need to intervene is on the learning mechanism. And he even talks about, like, you know, potentially there is a neurotransmitter piece that we could intervene on. That's not how I intervene on things. I'm like, how can we make that happen through our experience, right? And this is why for the person with runner's dystonia, with writer's dystonia, with musicians' dystonia, we can impact by changing the task altogether, by changing the sensory environment, by introducing variability. And this is a very huge part of dystonia training. Often what we see in folks with dystonia is that, particularly with idiopathic, really, really repetitive movements, that the musician who's played the same piece over and over, the runner who is running at the same pace on the similar pathway in the same shoes over and over, and so on, is when we can introduce variability to practice conditions, it helps with the unlearning. Essentially, it's laying down new pathways. I often think about it this way. If the learning that occurred that developed the pattern in the first place is kind of like, I don't know if you bike or mountain bike, but I used to mountain bike. But if you've ever been on a trail, you kind of see the well-worn trail, the ruts where people keep going, right? And dystonia, like that rut to me is like super deep in a very particular pattern. And it takes us like changing that pattern. Like we have to totally get out of that rut. That's like, if you're a runner, that's like going from running forward to running backwards. So now you're on a different trail, right? So you're outside of that. But how do you get back to running forward again when your body has trouble unlearning that pattern? And so this is a very long process, especially if it's a very deep rut. You are going kind of like layer after layer of almost like filling in that rut with different experiences. That's how I really envision it. But I love this idea of, in many ways, we need to kind of forget the rut. We need to develop an entirely new pathway, and not just one, right? So a lot of people with runner's dystonia, for example, they're like, okay, I'll change my shoes and I'll start running at this different pace, at this different pathway. But then they do that repeatedly, right? Rather than, instead of just establishing a new rut, we need to establish like 16 different ruts and start using all of those to not have the same thing occur in idiopathic dystonia. Now, I think I'm going to go back here. So I think this is a really helpful thing to think about idiopathic dystonia, this ability to forget. How can we help somebody lay down new neural pathways and develop new neuroplasticity by forgetting a learning pattern? I think that is just a brilliant challenge for us as clinicians. And I also think this is something that we can consider in functional dystonia. And this is, again, where I think Mark Hallet and I will diverge. And I'm totally like, I'm such a fangirl of Mark Hallet. But I just disagree with this, because he talks about, he specifically says functional dystonia does not have abnormal plasticity as far as we know. So I'm going to share a few links to show functional dystonia does have abnormal plasticity as far as we know. Now, have the same studies been done in functional dystonia as idiopathic dystonia? No. But here's one of them. And I see a comment here. Can you please put up links for the references? So yes, if you are not on my newsletter, get on the newsletter. You can comment on the post that is in our profile right before this one, or once this one is the recording is up, you can comment there. I'm going to share links to all of these articles on there. I can't really share links to the articles. You can't click on links in Instagram. It's really annoying. So I wanted to share several articles that show abnormal neuroplasticity in functional dystonia. So yes, we do know this occurs in idiopathic dystonia, but I'm just gonna have to disagree with you, Mark Hallet. I think it occurs in functional dystonia. We might have different definitions, maybe. Somebody is asking the question mark about plasticity. So we're talking about neuroplasticity, which is essentially that the brain can make changes in connections, changes in the network function. So this can be measured several different ways. And this particular study, I'm not going to go into detail. I just want to give you some resources and some, like, this is my rebuttal to this statement, that there are cortical changes. There are neuroplastic changes that are driving functional dystonia as well. So cortical inhibitory imbalance and functional paralysis. This one looked at things that have also been looked at in idiopathic dystonia, particularly with transmagnetic stimulation, and showing differences in people with functional dystonia. Here's another one. This particular study was not a study, it was a review article, and they talk about the neuroplastic changes in functional neurologic disorders. So this one's called Understanding Functional Neurologic Disorders, Recent Insights and Diagnostic Challenges. And then let me give you one more that is specific as well. And this is neuromodulation. So neuromodulation meaning primarily transmagnetic stimulation, which can be used to both assess neuroplastic changes and treat neuroplastic changes. This particular study looked at it in terms of treating functional neurologic disorder. Mixed results on the treatment of it, but some evidence that there are neuroplastic changes happening in functional neurologic disorder. Now, I also want to share some of the evidence for treatment of idiopathic dystonia. So because he essentially is saying, like, it's not very treatable. Now, is it easy to treat? No. Does it get better overnight? No. Does it take consistent practice on the person with the dystonia? Yes, indeed it does. Does a person with functional dystonia need the same level of repetition and practice? No, they don't. So when I think about functional dystonia and when I think about idiopathic dystonia and that like rut that I talk about, like similar to cycling and getting how deep those ruts are, I think of the idiopathic dystonia having a very, very deep rut, and the person with functional dystonia having a smaller rut and having variable ruts. So in idiopathic dystonia, in functional dystonia, you might not need the same amount of treatment for resolving that pattern, because it is not such a highly learned pattern. It is more variable. And that variability is actually really helpful for those neuroplastic changes. So it might get better more quickly, but it might not. But I wanted to share this because we shared this in Julie Maggio and Heather Salon and I did a CSM presentation last year on sensory treatment, and we shared some of the dystonia evidence. And there you see it. You've got the article, you have the key findings of things that we can do for the sensory system. And when I think about this, I like literally think about neuroplasticity. I think about brain changes. When we change the input to the system, we can change the output. And no, Mark Hallet was not talking about this in this particular, and this was like a 1 page, right? He only had 1 page. So it's okay, Mark Hallet, I forgive you for not talking about sensory treatment. And these are really small studies. These are not big randomized controlled trials, but addressing the sensory system can really help dystonia. It also helps functional dystonia. The other thing that I really want to point out is while we see dystonia, as a motor disorder, involuntary movement occurring in idiopathic dystonia. This is from an article about idiopathic dystonia, but I just want to point out it's so similar to functional dystonia in that you see these motor symptoms, but there's so many other pieces. So much of the iceberg is not seen. Pain, fatigue, balance changes, sensory abnormalities. All of these pieces we now understand are part of both idiopathic dystonia and functional dystonia. So while I agree, Mark Hallet, the motor output and learning is a really big, important part of idiopathic dystonia, it is definitely not all of it. And I think this is where, and I totally understand, Mark Hallet is a neurologist, probably the best movement disorders neurologist in the world. He's not treating these day to day. And the research isn't really like looking at like, what if we treat all of this together, right? Like, what if we take the whole person and look at all of these pieces together? Then can we make a difference? He is right. If we just like do this with our hands, if we just try some of the opposite movements of the dystonic movement, it's not helpful. And that is exactly true. That is what he talked about in here. But if we zoom out and take a bigger look at the person, there is so much that we can do to change the brain, to help that person get back to their life. To me, that gives us so much hope. Now, I saw a question come through. By the way, questions. I would love your questions, would love your comments. Put them in here as we wrap up. So this question is, which one is it if your dystonia develops after a foot sprain? The thought of my foot touching the ground would make my calf tighten up. Very interesting. So I'm going to put up this picture again. I would say if it's coming after an injury like that versus repetitive movement, I'm leaning towards that's a functional dystonia. So because functional dystonia typically occurs after a physical injury. It happens alongside pain a lot. CRPS often has dystonia associated with it. But I'm not a movement disorder neurologist. I am not a diagnostician. I don't give diagnoses to people, but you can see the differences here in idiopathic dystonia versus functional dystonia. Now, if you told me you sprained your ankle while running because your foot has been turning in repeatedly for a year and you didn't know why, I would say that might be runner's dystonia and idiopathic dystonia. However, as I mentioned at the beginning here, you can have both. Functional dystonia can co-occur with idiopathic dystonia. Functional neurologic disorders can co-occur with other neurologic disorders. In fact, it's quite common that they do. And I think the good news is both are things that can be treated and respond to a lot of the same types of treatment, for example, like sensory training, autonomic training, and all of that. So really, really great question. And if you don't know, if you haven't gotten a good diagnosis, you should definitely see a movement disorder neurologist. I have had patients go see Mark Hallet. He is at the NIH, and they go and see him and get a really great diagnosis. You don't have to go see Mark Hallet, but I've had patients do that, which I'm always like, oh my gosh, you're so lucky you got to see Mark Hallet. But a movement disorder neurologist specializes in dystonia. When people present with dystonia without a diagnosis, and not knowing what it is, that's who I'm going to send them to. Okay, another great question comment here. I use a loud metronome. Here, I'm going to stop sharing this for a moment. I use a loud metronome on headphones and change the tempo speed when it occurs running, which helps, but it doesn't stop it reoccurring every time I go running. I'm not surprised. If you have runner's dystonia, you've got a super deep rut of learning, and you have found, which is very beautiful, that changing tempo changes it, which is great. And this is what a lot of people do initially when they're first diagnosed. I'm just going to tell you, and I wish that this wasn't the case, it's just not enough. So if you think of that rut that has been built with abnormal neuroplasticity, and it's super deep and it's well-learned pattern, changing one thing is going to help. It might help temporarily, but it's not enough. So you need other variables there. You need sensory variables, autonomic variables, environmental variables to go alongside of it. And it's going to take, like this, I wish this wasn't the case, right? Like, you know me, I mean, if you know me, I'm a very optimistic and very hopeful person, but I am going to be really honest. This takes a lot of time and practice. And this is what I appreciate about the Mark Hallet article, is he's like, yeah, this isn't easy. This is super set in your brain. And there's going to be a lot of unlearning that needs to be done. I am so thankful you found the tempo piece, but it just needs other pieces, without a doubt. Yeah, Ellen says sensory input really helps me with where my leg and foot are in space. Yeah, so that's another thing that we know and understand with dystonia, is that the sensory map gets distorted. So where you, like, understanding where your foot and leg are in space is distorted. You don't have a good map of the body, and the sensory input can be helpful. John is asking, I have functional dystonia. Will EMDR and TMS therapy help? It's a really great question. And honestly, John, I shared one article here, which wasn't on functional dystonia. It was on functional neurologic disorder in general. And it looked at TMS as a treatment modality, and mixed results, very, very small studies. Most had some positive outcome, but might not be that different from placebo. It doesn't have a lot of side effects, so that's going for you. Now, EMDR, so he's asked about EMDR. This is a therapy. I've actually done it myself with my psychologist. That's done with a psychologist, really, and it's research-based, focus on trauma. Now, if not everybody's functional dystonia is associated with trauma. In fact, a good percentage of people are not. So EMDR would not be helpful for functional dystonia if your dystonia wasn't related to trauma. So sometimes, actually maybe often, people with functional neurologic disorders, functional dystonia, only get referred for psychological treatments. Now, I love psychological treatment. Like, I'm in therapy every single week. I believe it has transformed my life. However, your movement disorder might have other pieces associated with it. Now, EMDR, TMS, also not a lot of side effects of those pieces. And those could be really helpful, particularly the EMDR, if your functional dystonia is related to trauma. So thanks for asking the good question. Yeah, and then back to, we were talking about tempo for this, for Spanner Soph. Good comment. It leads to repeated hip injury tears, then I can't run and I try again and it happens again. So I can't build longer distance. Yes. So absolutely. So this is one of the things. So we see a lot of people with runner's dystonia. And what occurs when you're running and with abnormal involuntary muscle contractions is you can land funny on your feet, you can fall, you can injure yourself. And as this person is sharing, repeated hip injuries and tears. And what you notice then is just taking a break and going back to it isn't enough. And I think that's another thing that Mark Hallet really talked about in this like perspective piece, is that learning is deep and very hard to forget. Even if you take time off, even if you stop running, there needs to be a retraining component to it. And it is hard. It is hard. Somebody asked TMS, question mark. So TMS is transmagnetic stimulation. It is something that has been researched. One of my great mentors at the University of Southern California actually has done some really lovely TMS research. It's been researched in many populations. It has been FDA approved for treatment of depression, but it's been used in Parkinson's. It's been used post-stroke. They've researched it in functional neurologic disorders. But maybe we'll have to do a talk on TMS. This isn't really my expertise. It's not something I do, but it is something that is really focused on changing some of that brain network connectivity. Yeah, Ellen, thank you for sharing this. She says, this has been a year of progress with a lot of work. It takes time. I appreciate you so much sharing that, because it does take a lot of time and a lot of work. And I know, because I've been following your story, Ellen, and seeing the changes, and I know, that you had therapy with us, but you have to keep doing it, and you keep going, and you keep making progress, which is really beautiful. And it's a testament to your determination to keep doing it. And by the way, I am not saying other people are not determined. I have never met a person with dystonia or FND who wasn't determined. I think people are determined. I think sometimes they just don't have the right pieces to spend their time on. And I love this. John is sharing, I'm also working with Neil Durans. I'm not sure who that is. He's teaching us how to heal through mind and body during hypnosis. Oh, hypnosis is another area that can be really helpful in functional neurologic disorders. And he's sharing, I have PTSD from childhood and stress overload. So John, I think you are down a beautiful path for you. And I think combining that with retraining your mind-body connection and your movement is gonna I have great hope for you really recovering from this. Another one, I was diagnosed with laryngeal dystonia, spasmodic dysphonia a year and a half ago. And as a singer, I just want to say I've seen singers with this. Of course it could occur in a singer because you frequently use your voice. And as a singer, it's been a very hard time, and I don't know what to do. I don't want the Botox procedure. And I want to tell you, people can get better with these. So laryngeal dystonia, spasmodic dysphonia is an idiopathic dystonia that can occur in a person like a singer, a person who talks a lot. It comes from repetition. And just like in running, right? Just like in musicians, just like in writers and artists, you're an artist and this is your instrument, your voice. It can get better. So it can absolutely get better. We've worked with people where it gets better. If people didn't know, we run a dystonia program, PT, OT, speech therapy, psychology. I think it really takes a whole person approach, looking at all those pieces together to start to change the brain. And this is my piece. You see the outcome of the dystonia as muscular contraction. We know from a brain standpoint, it's much more complex than that. And I think if you're not addressing the brain, my motto is no brain, no gain. Like, if you're not addressing the brain, you're not going to see some of those changes. And I think for you with laryngeal and the spasmodic dysphonia, that is sensory, it's motor, it's autonomic, it's lifestyle, it's so many pieces of the pie. As Karen is saying here, all neurologists see injections as the gold standard. So, great question. Is that not true? So, I'm going to give you a big it depends. So, the trialing medication, a lot of neurologists will trial medication for dystonia, like Cinemet, to see if it's responsive to dopamine. Medications such as Botox are another piece that have been found to be effective, especially in idiopathic cervical dystonia. Botox is not effective in functional dystonia, and it has, I still see people try it. I've seen some people have some effect, but very limited effect in some of the other focal dystonias. But I will say, when I see somebody with idiopathic cervical dystonia, I work really closely with them and their physician to time therapy with their Botox to have a maximum effect. Ellen says, thank you. And the Dystonia weekly class is so helpful as well. I'm so glad. I'm going to tell Lincoln that you said it. Lincoln, our neurologic physical therapist who runs our Dystonia program, teaches a weekly online education class for people with dystonia. Ellen's a part of it. It keeps you going. You keep learning more about the brain and the body. That's something that we have online. Anybody all over the world can access it. Thanks for sharing that. Somebody else asked, has visualization shown to be helpful for this? Really great question. So I always preface, what do I know in the research? And I don't think that I have seen a research study looking at mental imagery or action observation specific to dystonia. However, I will tell you, we use this a lot. So from a clinical standpoint, I will tell you this has been very effective. So we do this in several different ways. So we might do visualization of the movement, along with some guided imagery. So our OTs or psychologists do a lot of those pieces, but we actually do a visualization typically in a video while the person is moving. So we might do a video of somebody else's feet, or we change the person's feet and they watch their feet without dystonia while they are running, walking, doing their activity. This has a remarkable impact on the brain. So yeah, I think it's a really great one. And then John is saying, thank you for encouraging us. Neil has a different kind of dystonia. His wife told him, your brain got yourself into this and your brain got yourself out. I love that. It is true for functional dystonia and dystonia. Your brain got yourself into it. Your brain can get yourself out. I love that. And you know what? If you don't attend to your brain, no gain. You've got to attend to the brain aspect of dystonia, not just the muscles. It's so much more than muscles. So once again, I'm going to wrap it up. Wow, we've almost been like an hour here. Thank you. Thank you so much for your questions and things. And we were reviewing this article, Dystonia, the ability to forget, But we went a lot deeper. We talked about the differences of functional dystonia and dystonia. We talked about why I didn't agree with some of the things in here, but I think overall the message that learning is so ingrained, and this like memory of, and that learning is so hard to change, but not impossible at all. And I see a couple more questions, comments in here, so I want to address these before I log off. I have had F&D for almost 4 years now. I've done PT and OT, which has helped so much, yay. But now that I'm not in those therapies anymore, I find that my F&D is even better. Why is that? Well, first of all, I love that for you. And I will say, one of the things that we see, because we see people for intensive bouts of therapy, as people get back to life, as people start doing things, as people have less PT and OT, less medical appointments, they get even more better because they're engaging in life. So I just want to celebrate that for you. More PT and OT doesn't always mean better, especially if you get to a point where you're getting better and then you are back to work. You're back to doing the things you love. All of those things promote positive neuroplasticity. I just love that for you. That makes me so happy. And another thing that Soph is saying, change in attentional focus. So sometimes when you're in PT, OT, there's like a lot of attention to your body, what's going on, and what you're doing. And so that also shifts when you're back to life. And that just makes me so very happy for you. John is saying, Neil suggested I don't go by the medical term, but that you have an emotional stress overload. And John, I'm just going to suggest what works for you, right? I think everybody is really very different about what can be really helpful to them. And if emotional stress overload is really driving your symptoms, it's helpful to know and understand that and treat that as you're doing. And John is saying, we're reading a book called Unlearn Your Pain. Thank you, John. Unlearn your pain, unlearn your dystonia, unlearn many things, because it's the brain that is making the changes. Really, really beautiful, really brilliant. As usual, I honestly learn so much from you, from your comments, from your questions. Thank you so very much. And again, I will put all of this in my newsletter this week. I have a newsletter for clinicians. I have a newsletter for patients. I send it out every week. Once we post this recording, you can comment newsletter. And if you're not already on it, get on it, because I'm sending a ton of resources and references this week. And so very thankful. Thanks for being curious about the brain with me. Thanks for wanting to dive into articles with me. I love it so very much. And I will see you again next time. Thank you so much. Oh, when am I doing my next live? Great question. I'm going live next week with a person with F&D. I'm very excited to do this with Camila Tan. So we'll announce it ahead of time because we're going to actually take questions. So follow us on Instagram, watch our stories. We're going to post to ask questions that we can answer in the live. So thank you so much for asking that question. We'll be back next week. And of course, you can send us a direct message on Instagram with your questions as well. So thanks so much, and we'll see you next time.